Good afternoon. I'm Dr. Sneha, Senior Resident from Department of Anesthesiology, Sri Lakshmi Narayana Institute of Medical Sciences. And so today's presentation is on cardiac patient, evaluation of a cardiac patient posted for non-cardiac surgery. And these are the contents of my presentation. So first one being preoperative evaluation, risk stratification, investigations, clinical and surgical risk predictors, patients with stent, perioperative medications, anesthetic goals, intraoperative management, and postoperative management. So patients with coronary artery disease undergoing non-cardiac surgery are at an increased risk for perioperative complications like myocardial ischemia, cardiac failure, arrhythmias, cardiac arrest, increased morbidity and mortality. So the first one being preoperative evaluation. So the purpose of preoperative evaluation is to evaluate a patient's current medical status, to provide clinical risk profiling, to decide on further testing, to treat the modifiable risk factors, to plan the management of cardiac illness during the perioperative period, optimize the timing of surgery. Coming to history taking, we have to take history on the severity of the angina, comorbid conditions, treatment and medications the patient is on, surgeries and interventions which has been done in the past, hospitalization and previous surgeries, other associated conditions which the patient might have like diabetic, obesity, cerebrovascular and pulmonary disease. Now, history which is pertaining for like functional evaluation of the patient will ask for symptoms of orthopnea, paroxysmal nocturnal dyspnea, palpitations, syncope, and exercise capacity. So this is New York Heart Association classification of heart failure based on the symptoms and physical activity limitations. So class 1, there's no symptom and there's no limitation in routine physical activity. There's no dyspnea with walking, stair climbing, etc. In class 2, there are mild symptoms like mild dyspnea, angina, and slight limitations of ordinary physical activity. Marked limitation in physical activity due to symptoms, and symptoms occur with less than ordinary activity, like walking for a short distance, and they are comfortable only at rest. Class 4, it consists of like severe physical limitations. Symptoms occur while at rest, and they are primarily bed-bound. This is Duke's activity status index. So one METS, which is metabolic equivalence, is oxygen consumption by a resting adult, which is equal to 3.5 ml per kg per minute. And this tablet column tells about like what metabolic equivalence it's equal to what kind of exercise. Now, METS 1 is eating and working at a computer or dressing. And METS 2 is walking downstairs, walking in house or cooking. METS 3 is walking 1 or 2 blocks on level ground. And 4 is racking leaves or gardening. 5 is climbing 1 flight of stairs, cycling or bicycling. And 6 is playing golf, carrying cups. And 7 playing single tennis. 8 being rapidly climbing stairs or slowly jogging. 9 being jumping slow rope, like rope slowly, cycling. And 10 being swimming, running, jogging, and skiing, running rapidly. This all comes under 11 and 12. So based on this METS, the functional capacity is classified as poor, moderate, good, and excellent. Poor is less than 3 METS, moderate is 4 to 6 METS, good being 7 to 10 METS, and excellent being more than 10 METS. Patients having functional status of less than 4 METS are at an increased risk of perioperative complications. Coming to the physical examination part, first we'll see about the vitals. So any patient will measure heart rate, blood pressure, respiratory rate, and temperature. Coming to systemic examination, we have to look in for the 4 major systems: CVS, respiratory system, abdomen, and the CNS. In cardiac examination, particularly, we have to look in for JVP, peripheral edema. Displaced apical impulse can mean cardiomegaly. S3, S4 gallop can be there. Murmurs, pulmonary edema, and airway assessment is important. So these are few indexes which is useful for risk stratification before posting the patient to a surgery. The first one being Goldman Cardiac Risk Index. So here you have to see the history. If there is a myocardial infarction within 6 months, the score would be around 10. Age more than 70 years, score will be 5. Physical examination is 3, or if there's a jugular vein depression, it is 11 points, and significant aortic stenosis is 3 points. In an ECG, if the rhythm is other than sinus or a sinus rhythm with or without atrial premature complex on the last ECG, it is 7. 5 premature ventricular complexes per minute anytime before surgery, the point is 7. Other factors like poor general medical status, 3, and intraperitoneal, intrathoracic, or aortic surgery, it is 3, and any emergency surgeries, it will be scored 4. So the total points would be around 53. Now, based on this, we can classify into 1, 2, and 3 and 4 class. Now, class 1, the probability of cardiac death would be 0.2%. And class 2 would be around 2%, and class 3 would be around 2%. 4, it will be around 56% cardiac death risk. There is another criteria, which is Eagles criteria for cardiac risk assessment. So this age more than 70 years, the score is 1. Diabetic, the score is 1. Angina, Q wave on an ECG, ventricular arrhythmia, all these are scored 1. And the total will be 5. If there is less than 1, there's no need for any other invasive testing. 1 and 2, there will be non-invasive testing. And more than 3, the patient has to undergo an angiograph. This is Lee's revised cardiac index as the most commonly used one, the RCRI index. So here again, there are like 6 risk factors. One being a history of ischemic heart disease, high risk type of surgery, history of congestive heart failure, history of cerebrovascular disease, preoperative treatment with insulin, preoperative serum electrolytes being more than 2 mg per deciliter. Everything will be pointed to 1, and class 1, 2, 3, and 4 is there. Like class 1, the risk is around 0.4%, class 2, 0.9%, and 3, there is 6.6%, and for class 4, there is 11% of major cardiac event risk. Coming to the investigations, we'll start with some routine investigations like a complete blood count, renal function test, and serum electrolytes. In a chest X-ray, we will look for some cardiomegaly, pleural or pericardial effusions. In an ECG, we have to look for Q waves, any conduction abnormalities, and arrhythmias. Coming to exercise electrocardiography or stress testing. So the usefulness of this test is limited in patients with baseline ST segment abnormalities and those who are unable to increase their heart rate because of fatigue, dyspnea, or drug therapy. So the target heart rate is 220 minus age in years. So most sensitive in patients with a triple vessel disease or a left main CAV. The prognostic gradient of the ischemic response, it is graded in this way, where the risk levels are high, intermediate, low, and inadequate. High is where the ischemia is induced by a low level of exercise. So this means that the patient has less than 4 minutes, or the heart rate is less than 100, or the heart rate is less than 70% of the age predicted heart rate. Intermediate, the ischemia is induced by moderate level exercise. So the patient is having 4 to 6 minutes. Heart rate is around 100 to 130 or like 70 to 85% of the age predicted heart rate. Low is where there is no ischemia or ischemia induced at high level of exercise, where METs is more than 7, heart rate more than 130, heart rate more than 85% of the age predicted. Inadequate is where inability to reach the adequate target workload or the heart rate response for the age without an ischemic response. Coming to pharmacological stress testing, which is dobutamine echocardiography, patients were unable to exercise. Those with pacemakers and significant bradycardia will undergo this pharmacological stress testing. Intravenous dobutamine will be given, and this will increase the myocardial oxygen demand so that the patient need not have to run on a treadmill or do an exercise. It can assess both the left ventricular function as well as valvular function. It is avoided in patients with serious arrhythmias and severe hyper or hypotension. Coming to Holter monitoring, continuous ambulatory electrocardiographic monitoring is useful in evaluating arrhythmias, antiarrhythmic drug therapy, and severity and frequency of the ischemic episodes. Myocardial perfusion scans and other imaging techniques. So myocardial perfusion imaging using thallium-201 or technetium-99m is used in evaluating patients who cannot exercise or who have underlying ECG abnormalities that preclude the interpretation during exercise. Echocardiography, regional and global ventricular function can be assessed using an echo. Wall motion abnormalities, the size of the chamber, valve status, the pulmonary artery pressure, the ejection fraction can be detected from an echocardiography. Based on the ejection fraction, we can classify the LV dysfunction. When the ejection fraction is more than or equal to 50%, it is normal. And if it is between 41 and 49%, it is mildly, there is an LV dysfunction. 26 to 40%, there is a moderate LV dysfunction, and less than 25%, it is severe. The last one would be coronary angiography, and this should be performed only to determine if the patient may benefit from a percutaneous coronary angioplasty, which is BPCA, or a coronary artery bypass grafting, CABG, prior to a non-cardiac surgery. Now, this one is class or like strength of recommendation for every investigation. Class 1 suggests that it is highly recommended. Strong recommendation where benefit is more than the risk. Class 2A and Class 2B are moderate and weak strength where the benefit is higher than the risk. In Class 3, there is no benefit, like benefit equals the risk. And Class 3 is when you do this test, the risk is higher, more than the benefit. So based on this, this is a summary of recommendation for supplemental preoperative evaluation. First being the 12-lead ECG. So preoperative resting 12-lead ECG is reasonable for patients with a known coronary artery disease or other significant structural heart disease. So again, this is not needed for a low-risk surgery. Now, this comes under moderate recommendation, which is 2A and 2B. Routine pre-op 12-lead ECG is not useful for asymptomatic patients undergoing low-risk surgical procedures. So this is class 3. Okay. Now, assessment of the LV function. It is reasonable for patients with dyspnea of unknown origin to undergo preoperative evaluation of the LV function. This comes under moderate strength of recommendation. And routine preoperative evaluation of the LV function is not recommended, which is class 3. Exercise stress testing for MI and functional capacity. For patients with elevated risk and excellent functional capacity, it is reasonable to forego further exercise testing and proceed to the surgery. So, when the METS is higher, it is okay to forego the further exercise testing and can be proceeded for surgery. This comes under moderate strength. Okay. Now, routine screening with non-invasive stress testing is not useful for low-risk non-cardiac surgery. CPET, which is cardiopulmonary exercise testing, may be considered for patients undergoing elevated risk procedures. Again, comes under moderate class. Now, non-invasive pharmacological stress testing, routine screening is not useful for low-risk non-cardiac surgery. Routine pre-op coronary angiography is again not recommended and it is class 3, where there is no benefit. So this is a flow chart we follow for a cardiac patient posted for a non-cardiac surgery. When a patient is scheduled for the surgery, you have to see if it's an emergency or not. If it's an emergency, do a clinical risk stratification and proceed to the surgery. If it is an emergency, you have to see if it is an acute coronary syndrome. If it is an acute coronary syndrome, go and treat it according to the guidelines directed medical therapy. If it is not, then you can estimate the perioperative risk. If there is a low risk, there is no need for any further testing and it can be taken up for surgery. If there is an elevated risk, you have to look in for the meds. If it is more than 4 meds, like it can be excellent, like more than 10, or it can be more than like 4 to 10. Then again, no further testing would be needed and you can proceed to the surgery. If it is poor or it is unknown metabolic equivalence, then go with pharmacological stress testing. Again, if this is normal, you can proceed to surgery. If it is abnormal, go for a coronary revascularization. Now, this is the clinical predictors of perioperative cardiovascular risk. First, these are all major clinical predictors like an unstable coronary syndrome, decompensated congestive heart failure, significant arrhythmias, severe valvular disease, and intermediate clinical predictors would be mild angina pectoris, prior myocardial infarction, compensated CHF, or a prior congestive heart failure, diabetic. Minor clinical predictors would be advanced age, abnormal ECG, rhythm other than the sinus rhythm, low functional capacity, history of stroke, uncontrolled systemic hypertension. This is surgery specific heart risk factors. In a high risk procedure, the reported cardiac risk would be more than 5%. So, in emergency major surgery in an elderly person, aortic and other major vascular surgery, peripheral vascular surgeries, anticipated prolonged surgical procedures which is associated with large fluid shifts and blood loss. In intermediate risk procedure, the cardiac risk is usually less than 5%. It is like carotid endarterectomy, head and neck surgery, intraperitoneal and intrathoracic surgeries, orthopedic surgery, and prostate surgery. Low risk procedure where the cardiac risk is less than 1% consists of endoscopic procedures, superficial procedures, cataract surgery, and breast surgery. Coming to the next topic, where a patient with coronary stent has been posted for a surgery. Now, PCI is percutaneous coronary intervention. It started with balloon angioplasty. A balloon angioplasty involves like insertion of a balloon into the coronary artery, wherever there is narrowing, and then you have to inflate it. Now, types of this PCI is balloon angioplasty, bare metal stent, drug-eluting stent, and bioabsorbable stent. Bare metal stent. So, the body is made up of stainless steel mesh. It will recoil at the constriction point. It will hold the vessel wall up. This will be followed by endothelization. The disadvantage is restenosis can occur due to neointimal hyperplasia, and there is increased thrombogenicity. Incidence of this rethrombosis can be reduced with dual antiplatelet therapy, which is aspirin and clopidogrel. Coming to drug-eluting stent, so there are 3 parts for this stent. The first one being the platform, the polymer, and the drugs. So the platform can be made up of stainless steel, cobalt, or platinum chrome. So these are more thinner, stronger, the conformability is better and less thrombogenicity. The polymer is the coat. This will carry the drug and it will slowly release it. The drugs are anti-proliferative substance. This will decrease the neointimal hyperplasia and smooth muscle proliferation. Paclitaxel, sirolimus, everolimus, and zeratolimus are the drugs, which are the anti-proliferative substance, which is used in this drug-eluting stent. As the drug is slowly eluded by the polymer, endothelization will occur. Now, this potent need is for a platelet microthrombus formation. That is why we are starting upon the antiplatelet therapy. Bioabsorbable stents are like the newest one and they are still in phase 3 research stage. The magnesium alloy polycarbonate polymer is this what is made up of. The radiolucent and temporary support till the polymer will release the drugs. Considered to be less thrombogenic and avoids the disadvantage of a metallic state. Complications of the stent: acute vessel closure secondary to thrombosis, vessel dissection, and restenosis due to vessel recoil can occur. Smooth muscle proliferation and neointimal hyperplasia can lead to restenosis. Stent thrombosis can occur. If it occurs less than 24 hours, then it is acute. 1 to 30 days after placement of the stent, it is subacute. And less than a year, it is late. And more than 12 months, it is very late. So, the complication will be acute vessel closure, smooth muscle proliferation, neointimal hyperplasia, and then stent thrombosis. Coming to the pathophysiology of the stent thrombosis, there are two pathophysiology. One being abrupt discontinuation of a dual antiplatelet therapy. So what happens when you suddenly stop a dual antiplatelet therapy is something called a rebound effect. There will be increased inflammatory prothrombotic state. Excessive thromboxane A2 will be produced. During surgical interventions also, there will be cytokine neuroendocrine mediator release. Now, this will have an increased procoagulant factor release. The prothrombotic state with incompletely endothelized stent, there will be stent thrombosis. This will lead to perioperative myocardial infarction. So, this flow chart is for a patient who's posted for a surgery with the coronary stent. So, stent implantation has taken up like less than 4 to 6 weeks. If it is yes, less than 4 or 6 weeks. If it is an elective surgery, we will delay the surgery until optimal period. If it is not, it's not an elective surgery, you have to continue the dual antiplatelet therapy unless the risk of bleeding is greater than the risk of stent thrombosis. Now, this implant, we have kept the stent, it is more than 4 to 6 weeks. If it's not more than 4 to 6 weeks, then you have to see if the risk of surgery delay is greater than the risk of thrombosis. If it is a yes, proceed with the surgery. If it is a no, you can delay the surgery until the optimal period. Now, does the surgery demand like discontinuation of the P2 Y12 inhibitors? If it is yes, continue and restart. Continue the procedure and restart it. If it is not, then continue the current dual antiplatelet drug therapy. Now, we were talking about this optimal period. So, what is that optimal period? So, for a previous PCI, there are 3 types, right? So, for balloon angioplasty, the optimal period would be 14 days. If it is less than 14 days, you have to postpone any non-urgent surgery. And if it is more than 14 days, you can proceed to the surgery. You can continue aspirin. If it is a case of bare metal stenting, then a minimum of 6 weeks and optimally it is more like 3 months, you can proceed to the surgery with aspirin. If it is less than 6 weeks, you have to postpone any non-urgent surgery. For a drug-eluting stent, it is 12 months. Less than 12 months, you postpone the surgery. More than 12 months, you can proceed the surgery, but aspirin should be continued. Coming to perioperative medications. So continuation of beta adrenergic receptor blockers like propranolol, atenolol, esmolol, and metoprolol, it is needed because this will avoid beta blocker withdrawal. So when there is a beta blocker withdrawal, there will be increased contractility and there will be increased heart rate, which is tachycardia, which is not needed. Now, ACC and AHA guidelines, they have to continue beta blockers. It's a class 1 indication. Coming to vasodilators like nitroglycerin, nitroglyceride, hydralazine, prazosin. So these will decrease the ventricular wall tension. Currently, trials don't support their prophylactic use. Aspirin, statins, they should be continued perioperatively. Coming to a patient who is taking aspirin, which is 75 to 150 mg per day. If the patient is starting aspirin as a primary prevention, you have to stop the drug like 7 days before a surgery. If it is for a secondary prevention, that is after a myocardial infarction, ACS or stent or stroke or PAD, then you have to continue except for intracranial neurosurgery. When the patient is taking aspirin plus a clopidogrel for like 75 mg per day, if it is a high risk situation, which is less than 6 weeks of MI, PCI, or a bare metal stenting or a stroke, less than 12 months after a drug-eluting stent, only for vital surgery, we will continue clopidogrel. Otherwise, in a low risk situation, we have to stop clopidogrel and you have to continue aspirin. Coming to the anesthetic goals, this is very important. Like the anesthetic goal we have to maintain for a patient, a cardiac patient posted for a non-cardiac surgery, is the first and the most important one is to prevent increase in the sympathetic nervous system activity. So we have to decrease the heart rate, preserve coronary perfusion pressure, decrease myocardial contractility, preconditioning the myocardium against stunning and infarction is necessary. So pre-medication, we will use an anxiolytic, sedative, it should be used. Continuation of other medication which the patient is already taking like a beta blocker and statin. There are few techniques of anesthesia for these patients. One being regional anesthesia, combined regional GA, and then there's general anesthesia. So each technique of anesthesia will have its own advantage and disadvantage. We'll discuss about that. So the first one being regional anesthesia. So advantage is there'll be a greater reduction of the intraoperative stress response. There'll be reduction in hypercoagulability and thrombotic events. Better quality of analgesia. We can provide a good pain relief with regional anesthesia technique. Disadvantage is loss of the sympathetic efferent tone. So there will be like rapid hemodynamic deterioration. In a patient who is dependent on the sympathetic tone, this can also precipitate a cardiac arrest. So this is the only disadvantage where there's a loss of sympathetic tone. So rapid hemodynamic deterioration, where there's hypotension, tachycardia can occur. Vigilant monitoring, and we have to maintain or control these sympathetic responses when you're planning for a regional anesthesia in these patients. Coming to general anesthesia, so this is the most common anesthetic technique used for a cardiac patient undergoing non-cardiac surgery. So volatile anesthetics and opioids. So these will antagonize adrenergic responses to stress. Intubation, there'll be sympathetic stimulation, hypoxia, and increased catecholamine levels. And there'll be loss of subjective monitor, which means that the patient will not be able to complain if there is a chest pain or an ischemia because the patient is under general anesthesia. The required monitors for this case would be an ECG, which is electrocardiography, non-invasive blood pressure monitoring, NIBP, pulse oximetry, capnography, invasive blood pressure monitoring through an arterial line, and central venous pressure monitoring, temperature monitoring, and urine output monitoring. Coming to induction, IV induction, we will usually avoid ketamine. So because ketamine will cause increase in heart rate, blood pressure, myocardial oxygen requirements will also be higher. Now, intubation, it should be a short duration of direct laryngoscopy, which should be less than 15 seconds. There are few drugs which can be given at the time of intubation to minimize the pressor response, again, which is tachycardia. So there will be IV lidocaine, esmolol, fentanyl, which is an opioid, can be given. Maintenance with a balanced anesthetic technique where you give a volatile anesthetic, nitrous oxide, and opioids. Muscle relaxant, vecuronium, rocuronium, or a cisatracurium can be used. Reversal using neostigmine and glycopyrrolate. Coming to post-operative care, so maintenance of adequate oxygenation is important in the post-operative ward. And you have to maintain normothermia, which is temperature, normal temperature. Hemodynamic stability, which is normal like heart rate, blood pressure, everything should be maintained. Fluid balance, pain management. Otherwise, when the patient is in pain, it may lead to tachycardia. and anti-ischemic medical therapy should be continued. So these are my references. So just for some revision, so what we saw was a patient with coronary artery disease. He's undergoing a particular surgery. And what are the complications we expect? About the pre-op evaluation. What is the purpose of a pre-operative evaluation in these patients? About what are the history you'll be taking and the history for functional evaluation. What are the symptoms and signs the patient has? We also saw the NYHA classification and the Duke's activity status index. Now, based on this METS, how the functional capacity is classified, like poor, moderate, good, and excellent. If it is less than 4 METS, then there is an increased risk of perioperative complication. Physical examination about vitals, systemic examination, cardiac examination, airway examination, this have to be done for all the patients. We also saw about the risk indexes. We saw about Goldman risk index, Eagles criteria, Lee's revised cardiac risk index, and also some investigations. So there was CBC, RFT, serum electrolytes. There was chest X-ray, ECG, exercise testing, pharmacological stress testing, which is dopamine echocardiography. And then there's Holter monitoring for arrhythmias. Myocardial perfusion scans and other imaging techniques. Echocardiography, which is very important. And based on the ejection fraction, how do you classify the left ventricular dysfunction? And lastly, finally, we also saw about like coronary angiogram. We saw about the recommendations. There's all the summary about ECG, LV function testing, exercise stress testing, cardiopulmonary exercise testing, all non-invasive procedures, and coronary angiography. Everything comes under moderate. So the flow chart, clinical predictors, and surgical predictors. Coming to coronary stent. So all the types of coronary stenting, balloon angioplasty, bare metal stent, drug-eluting stent, and bioabsorbable stent. So we saw what is made of and all. And the disadvantage with this bare metal stenting is actually restenosis and thrombogenicity. That's why the patient will be started on an antiplatelet therapy. And we also saw about drug-eluting stents, platform, polymer, the drugs, all paclitaxel, sirolimus, everolimus, xeratolimus are the drugs which we use, and this will decrease the hyperplasia and smooth muscle proliferation, which is not present in bare metal stenting. So that's the difference between both. Then we saw about bioabsorbable stent, which is still in phase 3 research stage. We saw about complications. Stent thrombosis is very important in pathophysiology, which is abrupt discontinuation of dual antiplatelet therapy, which is aspirin, clopidogrel, and surgical intervention. When this may like it will all increase the inflammatory prothrombotic state. So that is why there's a perioperative MI. Stent thrombosis, which will lead to perioperative MI. We saw about the flow chart with coronary stent. This is very important. Like when the patient has had a balloon angioplasty, you have to know like the recommendations for timing of the non-cardiac surgery. So for balloon angioplasty, it is 14 days. Bare metal stent, it is 6 weeks. For a drug-eluting stent, it is 12 months or a year. Perioperative medication, beta blockers, continue it. Vasodilators, trials don't support their prophylactic use in these patients. Aspirin statin should be continued perioperative period. So aspirin, if it's primary prevention, stop before surgery. If it is secondary prevention, you can continue the drug. Patient with aspirin and clopidogrel, if it is a high risk situation, vital surgery, you can continue unless the bleeding risk is more. And if it's a low risk situation, you stop the clopidogrel, continue aspirin. Anesthetic goals, again, most important thing where you have to prevent increase in the sympathetic nervous system activity. decrease the heart rate. We have to maintain coronary perfusion pressure, decrease the myocardial contractility, the heart rate, myocardial contractility, everything should be decreased. Preconditioning the myocardium against any and infarction should be done. We will give a pre-medication. It should be a sedative, anxiolytic. We will use it. Beta blocker, statins should be continued. We saw about like all advantage and disadvantage of different anesthesia technique. So in regional anesthesia, the disadvantage is loss of sympathetic efferent tone. So there will be like rapid hemodynamic deterioration. If the patient is dependent on this, then there can be a cardiac arrest. So to prevent this, most common technique we use is general anesthesia for these patients. Again, a balanced anesthesia where you give opioids, where you give volatile anesthetics and all. And intubation, there will be some stimulation. So we will give certain drugs to decrease the pressor response. Essential monitors. Yeah, so induction, ketamine is usually avoided. Intubation should be short duration, like less than 15 seconds. Drugs to minimize the response would be lidocaine, esmolol, fentanyl. These all will be given prior to intubation. Maintenance of anesthesia after intubation would be with volatile anesthetics, nitrous oxide, and opioids. Muscle relaxant can be used, and reversal is usual. Post-operative care, again, it's very important to maintain adequate oxygenation, normothermia, and hemodynamic stability. And also, if the patient has any drugs, we have to continue it through the post-operative period. Right. So, this is my reference. Thank you.